Hi, Kiran. Have you logged in?
Yes, ma'am.
Yeah, hi.
Am I audible?
You're audible. You're not
Yes.
visible though. So you can switch on
Uh,
video.
Actually, I'm at my home. So,
No problem, no problem. You'll have to
okay.
switch on your video when you're presenting, okay?
Okay. Yes.
Yes. So I'm so sorry I could not log in before for your discussions, but I think Dr.
Hmm.
Sanjit and Sushant have taken quite a bit of it. So,
Yes, yes. There was a connection problem actually the other day when we were rehearsing.
oh,
So we took a conference call and I asked my doubts.
oh, okay.
Yeah. I was in the hospital at that time actually. That's why the network was
Okay,
sketchy.
okay, no, no
Hmm.
problem. We'll just wait for Sanat and
Yes, yes.
Sushant. And I think Dr. Nilesh is also there as a moderator today.
Yes, yes, ma'am.
So you're in first year, right?
Yes.
You were also, I have a feeling I have seen you before in
I
Pune.
was,
You were in,
uh, yes, yes. I did my medicine from Dinanath Mangeshkar. So I
oh, okay.
took the quizzes
Yes, right,
in
correct. That's where I
education.
have seen you.
Yeah.
Gayatri, you were with Gayatri, yes.
Yes. I even did a 3-month observership with them in
That's,
Rumat. Since I was repeating, I was studying at that time. That's why.
how would you find it in Nair?
It's
Very,
good.
very
It's a
exhausting.
bit overwhelming to switch from DNB, like private hospital, to government hospital, but
Yes.
it's good. The patient load is really nice.
And your seniors are Kavya.
Yes. We are the second batch.
Acha.
Hmm.
So you are equivalent to our Nikita and Nayantara, or?
Yes.
Okay, okay.
Hmm.
Great. Okay.
Yes.
Okay, then let us
Ma'am,
wait.
is there another lecture today, or
No, no, no,
it's
it's
just
just you.
okay?
Hour and a half. Mostly an hour to, for you to do it, and we'll be also interrupting beach mein, no? So
Yes.
maybe we'll go as planned. Like you can finish the first part of your discussion, and
Hmm.
we can interrupt a bit and ask a few questions here and there, and then again go on to the methodology, so introduction, methodology. That way we can maybe proceed.
Yeah. Okay.
I'm just waiting for the others. Hi, Sushant. Good morning.
Hello, ma'am. Good morning.
Hi, good morning. So I think Deepak has some tragedy in his family, so he won't be joining.
Oh, okay.
Digvijay just texted me to start.
Okay.
He's
Okay.
also outside, but I'll wait. We'll wait for a bit. I think Sanath has yet to join,
Yes.
and students as well. Few students, whoever is interested.
So I can see two other accounts, iPhone and Dr. Rani. Are they students? I mean, are residents or
I don't
I don't
know.
know.
Yes, sir. Rani is my co actually.
Oh, okay. And
Okay.
I don't know who. Mine also haven't joined yet. I've told all of them to join. Take time. Follow residents as well.
I've shared my screen, sir.
Yeah, I can see that. Yeah.
Yes, yes. So you can make it to the presenter mode also. Slide share, what's that called? Slide
Full screen, yeah.
view.
Okay.
खाली button आहे बघ.
Oh, I know.
Yes. Yes, great. We can see it now. So I think Sanad has joined, I think. Yes. See that.
Hello, hi. Yeah, hi.
Hi, good morning.
Good morning.
Okay, so let's start this. I
Yeah.
think there's a tragedy with Deepak's family, and Digvijay is also outside somewhere, so they just asked me to start. Okay, so good morning, everybody. Welcome to the first journal club of this year. We aim to do at least 2 per year, if not 3, because in addition to case presentations, we feel that journal clubs help all of us, the students as well as us, to stay abreast of latest research, also evaluate methodologies in various types of studies, and we can critically appraise papers, right? So today the student has picked a basic sciences paper about interferons in inflammatory myositis. We know that interferon signature has a big role to play in inflammatory myositis. We still are in process of understanding how that works in different subsets. We also want to know the therapeutic implications of this. So today we have Dr. Kiran Wakade. She is senior resident in Department of Rheumatology, Nair Hospital, Mumbai, who would be discussing this paper. Along with me, the moderators for the session are Dr. Sanat Phatak. He's a clinical immunologist and rheumatologist with KEM Hospital, Pune. Dr. Sushant Shinde is a rheumatologist attached to Quest Clinic in Mumbai. And we also have Dr. Nilesh Nolkha, a professor in Department of Rheumatology, Nair Hospital, Mumbai, and myself as well. So without wasting further time, let's hand it over to you, Kiran. You can start.
Yes.
And I request
So
everybody else to keep their phones on mute, please. We shall have discussion, and you can put your questions in chat box. You can put your comments, and so let's start.
Yes. So good morning, everyone. I would like to thank my mentors for today, Dr. Sushant Shinde sir, Dr. Varsha Bhatt ma'am, and Dr. Sanat Phatak sir. So this article was published in Frontiers Immunology in February 2025. It is by Louis Bolko and team. It is mainly, the title is Ultrasensitive Interferon Quantification Reveals Different Cytokine Profile Secretion in Inflammatory Myopathies, and if it can serve as a biomarker of disease activity in dermatomyositis.
Kiran, you're not
So basic concepts in interferon biology in response to danger signals.
Yes.
Yes, ma'am.
You're audible. Now you're audible, but it's a little laggy.
Okay. Is it better now?
Yes, better now.
So I was discussing about some basic topics in interferon biology. Interferons are basically cytokines which are produced in response to danger signals. You can think of them as alarm signals which are produced in response to some intracellular threats, which could be a virus or some denatured material. So they are divided into type 1, type 2, and type 3 based on the receptors on which they act. Type 1 is the interferon, which is predominantly studied in autoimmune diseases. So if we go to measure these interferons, the blood levels fluctuate and they are hard to detect. It is a low abundance molecule, hence it is difficult to identify them directly. Hence, a concept of interferon signature has come into play, which is basically an increased expression of interferon stimulated genes in the blood or tissue. So it is mainly a surrogate marker of interferon activity. So most paradigmatic discoveries of interferon have been in lupus, right from 1979, where they found elevated serum interferon activity in SLE patients for the first time, to 2003, where they identified the concept of interferon signature in SLE, right till today, where we see interferon being targeted as therapies in lupus. So interferon has also been identified in diseases like dermatomyositis more than antisynthetase and other inflammatory myopathies, which we will be discussing today, and other diseases like primary Sjogren's syndrome, rheumatoid arthritis, systemic sclerosis. So how do we measure this interferon signature? It is mainly measured via a PCR-based assay, and they have also come up with an interferon score, which is nothing but a composite expression of the genes which are upregulated when the interferon is activated. And but this score is not a validated score, hence it is mainly used for trial purposes. So the interferons are also being studied in different previously studied in different myositis. The most established role has been for interferon 1 signature in dermatomyositis. The interferon 2 signature has been identified to be present in antisynthetase syndrome and inclusion body myositis. And still, they do not have any robust evidence for interferon signature in IMNM yet. A probable role of interferon 2 has been suggested. So coming to these interferons have been linked to pathogenic effects in dermatomyositis previously. They have been identified in biopsies of the muscle, skin, and vasculature of patients of dermatomyositis. So they are known to halt myoblast differentiation and cause myofiber atrophy via upregulation of the atrophic genes. They are also known to be expressed in the vasculature of these patients, producing ulcers and skin lesions. And the sites which are interferon activated via system, hence causing damage and skin ulcers. So is the quantification of these interferons the need of the hour? Why do we need them? And why might quantifying absolute interferon levels be better than identifying the interferon signature? Let's look at them one by one. So disease activity assessment in myositis remains difficult to date, mainly because the diseases are heterogeneous. They have different dominant domains. Some have extramuscular domain, which is dominant, like ILD and skin and dermatomyositis and antisynthetase, whereas they have different immunogenic drivers and they have different tempo of progression. And muscle weakness does not always reflect active inflammation. The MMT8 that we measure, it might not always reflect the function. Also, there is a poor correlation of the available biomarkers. And the measures for muscle activity that we have, they are mainly subjective. So these interferons being central to the pathogenesis, measuring them directly will help us stratify diseases. And interferon signature is actually an indirect and non-specific surrogate of interferon activity, and it has a poor temporal correlation. It is known to persist even after actual interferon levels have fallen. And to date, direct interferon measurement was not feasible. But with the new available assays, that is digital ELISA, we can now accurately quantify these interferons. So I would like to spend 2 minutes to differentiate what is a standard ELISA and what is a digital ELISA. So they mainly differ based on the substrate on which they are measured. So in standard ELISA, as we know, the substrate is a polystyrene plate, which is coated with antibody. And the signal is basically a continuous measure, which is the intensity of color, which is produced after adding the enzyme. Whereas in digital ELISA, the substrate are actually microvwells, which are filled with individual beads, and each individual bead is coated with a antibody. So when you pour the sera into this, each bead, that is each antibody, goes and sits into each microvell. So the ultimate result that we measure is actually, you can actually count the number of wells which are lighting. So basically, the digital ELISA, or the SIMOA, which is single molecular array, it is basically almost 1,000 times more sensitive than our standard. If you want to compare a simple analogy, the standard ELISA in a crowd full of clapping people, the standard ELISA will quantify the noise, whereas digital ELISA will actually give you how many people are clapping. So coming back to our study, the objective was to evaluate the presence of different types of interferons in idiopathic inflammatory myopathies and their subgroups using ultrasensitive cytokine detection technique, and to assess their potential as activity biomarkers. So let's see the methodology. The study design was a cross-sectional observational cohort. It was a single center study with a sequential cohort enrollment pattern. That is, they used two cohorts. First, they had a preliminary cohort to which they subjected their methodology, and the findings from this cohort were confirmed in a validation cohort. So in the preliminary cohort, they mainly included 4 categories of patients of dermatomyositis, antisynthetase, IBM, and IMNM, and they compared the findings to 33 healthy controls. And the findings of this preliminary cohort were validated in a validation cohort, which included only dermatomyositis and antisynthetase patients. So excluded from both the cohorts were patients who had increased dose of corticosteroids the week before sampling, and patients with active infectious disease like flu or viral hepatitis. A 5 ml blood was collected, 400 microliter serum per assay, and rapid freezing was done before 3 hours of centrifugation, and single thaw was used. For disease activity assessment, they used 4 core set measures basically. One was the manual muscle testing, the creatinine kinase levels. For extramuscular domains, they used the myositis disease activity assessment tool, which is again a subjective tool. And for physician global activity, they stratified the population into 3 groups. One is healthy donors, one is active disease, and one is inactive disease. So for laboratory assessment, they measured the interferon serum levels using digital ELISA for interferon alpha and interferon gamma. But for interferon beta, they used a standard ELISA because a kit is not available yet for measuring interferon beta yet. For defining a positive, they calculated the mean of healthy donors and added 3 into standard deviation. So they had positive cutoffs for each interferon. For myositis-specific antibody, they used the line immunoassays, which were commercially available, and they detected the following antibodies for dermatomyositis, antisynthetase, and IMNM. Let's go to the statistics. For quantitative variables like CK levels, interferon levels, they used median because our data was not normally distributed. For categorical variables, they used proportions. And they used the Kruskal-Wallis test while comparing more than 2 groups, like the 3 groups which we had, healthy, inactive versus active. And upon this, they applied a Dunn's post hoc test, which showed how the groups differed significantly or not. They used the Spearman's rank correlation to find out the correlation between different parameters with disease activity. And they used a receiver operating characteristic curve to find out a cutoff to define active versus inactive disease. And they used a Uden index to choose a best cutoff from the available ROC curve. P-value of less than 0.05 was taken as statistically significant. So I'll spend 2 minutes in discussing the ROC curve, the area under the curve, and Uden's index, because that is important for us in future graphs. So the ROC curve is basically a curve where on the y-axis we have true positive rate and x-axis we have the false positive rate. It is basically a curve which is plotted after taking the sensitivity and specificity for each result that we get. And it mainly, the area under the curve is the blue shaded portion. It mainly tells us the robustness of the study model that we have. And the Uden's index, it is mainly calculated via taking, it is the formula wise, it is sensitivity plus specificity minus 1. It is mainly the point which shows best sensitivity and best specificity for our available results. This horizontal line that we have is the line of no discrimination. So if our results fall on this, we can compare it like we are flipping a coin. The results are 50-50. So if we have to have a good test, the ROC curve should be touching the left upper corner. Discussing the correlation coefficients, which is R, because most of our results are displayed in terms of correlation coefficient. +1 indicates perfect positive correlation, 0 is no correlation, and -1 is perfect negative correlation. So our values will rank between a strong correlation, moderate correlation to weak correlation. So let's see the results. Ma'am, should I proceed?
Just let me stop you there. Any questions from our moderators so far?
No, ma'am.
No, I'm okay.
Right. So can you just enumerate the research gaps in the study? I mean, why did the study proceed? Why did they do this? Just for the
So
benefit.
like I said, so there was no study evaluating absolute interferon levels so far. There is one study which has been done in SLE, but in myositis, most of the studies are done on interferon signature. So that is one reason, one gap which is there in literature. And as I said, the disease activity assessment in myositis still is subjective. For the muscle as well as extramuscular domains, it is subjective. So we need an objective measure which will help us measure the activity of the disease.
Right. So what are the limitations in CPK? Because I'm just talking about it because that's what we use routinely in practice, right?
Yes, yes.
Part
So
of our
CPK, yes, ma'am. So CPK is not always elevated. Many times we tend to check aldolase and other muscle enzymes also. And even it doesn't always correlate with the amount of muscle weakness, but because the muscle weakness can be due to inflammation as well as damage.
Anything else? Does it tell you about all the domains of a myositis?
It doesn't, yes. It doesn't, yes. It doesn't tell about the skin, the lung, and...
Great. So we lack quantitative
musculopathy.
biomarkers is what you're saying.
Yeah. Yes.
Yes. Go ahead.
Can I just ask a few
Yes.
things about the ROC?
Yes.
Yes.
So, go back one slide. Okay. So for this analysis, would you agree in taking a Uden index, or would you have done something else?
For this particular study?
Yeah.
Yes, sir, I agree with taking the... Actually, Uden's index was a new parameter for me.
Okay.
But I agree with it, sir. Because we are chasing cutoffs here to differentiate active versus inactive. And in order to find the best cutoff, I think best cutoff from the available cutoffs, Uden's index is a good formula.
Okay. So for this test, what would you like? You want it to be more sensitive, or you want it to be more specific? So I mean, just to clarify, a Uden's index is just optimizing the two.
Yes.
So if you want to test, so there will be points along the curve which are more sensitive and less specific.
Yeah.
So if you see the optimal cutoff point that you have put, the J point, it's got a sensitivity of 80 and a specificity of 80. Both of these are not great.
Yeah.
So you will want to say that what you want this test to be, right? So if it's a screening test, you want it to be highly sensitive. You don't want to miss anything. So you can then go towards one side and say that I would like a fixed sensitivity of 90% or 95%, and then I'm okay with having a specificity of 50% because that maybe I'll have a confirmatory test for that later.
Yes.
If you want a test to be extremely specific, where the patients have already been screened. Now, for example, in this particular case, picking up things is not too important, is what I'm guessing, because they are already patients with inflammatory myositis. And you want it to be specific to a particular type of disease, say. So
Yeah.
then you can say that it's okay if it's not sensitive, and then you can move towards the right.
Yeah.
And say that I'm okay with compromising on sensitivity a little bit, but I need a high specificity. So what do you want this test to be?
So I think I would want this test to be more specific, definitely.
Okay.
Because two things, interferon levels are, it can be elevated in healthy controls also, in viral infections also. And as I said, it is a low abundance molecule. So
Right.
yeah, so I want the test to be more specific than sensitive. In order to clear, just to be sure that I'm identifying actual active disease.
Yeah.
Yes, so I would like it to be more specific, sir.
Okay. So usually what is done is when you're looking at a new biomarker, you first look at sensitivity. Because if it's not picking up patients only, then there is no real point being specific.
Right.
I mean, I'm just telling you all this so that you think about where you are on the curve. I mean, there's nothing right or wrong in this. Uden point is a good optimum to take because you're sort of trying to optimize for both. But usually, when a new test comes in, you'd want to see that it is reasonably sensitive, and then specificity can follow later if it's a completely new test.
Right.
Okay. Do you do you know why it's called the ROC? Why this curve is called a receiver operating curve or receiver operating characteristic curve?
Characteristic. No, sir. Actually,
So what is who is the receiver? What are they operating?
I think it was developed for some other use. I don't remember actually, sir. I don't know. I'm not sure.
Yeah, okay. I mean, this is not much to do with the articles, but it was developed in World War II to differentiate Japanese airplanes from other noise on radio receivers. And then they had to say that at each point, what is the sensitivity or what is the probability of this being an airplane noise, and what is the probability of this being other noise, birds or whatever else, or wind.
Okay.
So then they used to plot it and then take it up. So it's still called receiver operating curve because of that, although it has nothing to do with radios anymore. Okay, cool. I think you can go ahead.
Yes. Hello.
Sushant, you want to ask anything?
No, nothing from my side.
Yeah.
Go ahead, please.
Missing right now. Am I audible?
Yes, you are.
Yeah. So we'll go to the results. So this table is showing the baseline characteristics of the first cohort, preliminary cohort that we had. So we can see most of the patients are adult, with IBM population being in the elderly age group. And they have recorded the myositis specific antibodies, the baseline core set measures, that is MMT8 CK levels and extramuscular domains. And we can see that in terms of the baseline corticosteroid dose and immunomodulator use, the groups are almost matched. So let's go to the first graph, which is showing levels of type 1 and 2 interferons in different myositis subgroups. On the y-axis, we have the interferon alpha levels, and on the x-axis, we have the different subtypes. And this is a scatter plot basically, and each dot represents value of each individual patient. So we can see that interferon alpha levels are significantly higher in dermatomyositis and antisynthetase. In interferon beta, higher as compared to all of the groups actually. And interferon gamma, it seems to be almost uniformly elevated in all the myositis subgroups as compared to the healthy donors. So they also found out correlations of different interferon subtypes with core set measures. In dermatomyositis, they found that interferon alpha correlated more with the extramuscular domain than the muscle domain, that is CK and MMT8. Interferon beta had numerically higher values in the muscle domain, that is CK and MMT8, than the extramuscular domain. And in antisynthetase, we can see that interferon alpha was more elevated in the muscle domain as compared to the other two. There was no correlation for interferon beta. And in interferon gamma, it was more elevated in the muscle domain as compared to the extramuscular domain. These are just correlation coefficients. We can see that there is a moderate correlation, mild to moderate correlation, not a very strong correlation. For immune-mediated necrotizing myopathy, gamma levels correlated with disease activity, whereas alpha and beta did not. And interferon gamma correlated with CK levels also. In inclusion body myositis, interferon gamma correlated with CK levels, but not with MMT8. So they put these put these findings into a multivariate analysis in order to remove any confounding factors and to find out independent associations. So interferon alpha was associated with active disease in dermatomyositis patients, and the odds ratio was 9.5. In antisynthetase patients, interferon alpha showed statistically significant association with disease activity, and there was just a trend for interferon gamma, but it was not significant. And no interferon subtype was associated with disease activity in IMNM and IBM patients. So they, since these findings suggested more positive findings in dermatomyositis and antisynthetase, they formulated an independent validation cohort, including a separate group of patients of dermatomyositis and antisynthetase. And they found out that in dermatomyositis, there was good correlation between interferon alpha levels and disease activity, and the correlation with interferon beta was weak. Whereas in antisynthetase, there was only a trend for correlation between interferon alpha and disease activity. So this graph basically shows shows active versus non-active disease in dermatomyositis, antisynthetase, and IMNM, and compared it with interferon levels. So we can see in active patients, the levels were significantly higher than non-active. Same goes with interferon beta. In antisynthetase, it was interferon alpha, which was significantly elevated in active versus in non-active. Whereas in interferon gamma, it was actually interferon gamma levels were elevated in both the groups, and the difference was not significant. It looks to be numerically higher in the active group, but the difference was not significant. So this is the scatter plots for both the cohorts, summarizing that interferon alpha and beta in dermatomyositis, they show a positive correlation. Whereas in antisynthetase, we just have the interferon alpha, which is showing a positive correlation with disease activity. Whereas in IMNM, it is showing a positive correlation. Interferon gamma is showing a positive correlation with disease activity. So they put the findings into the ROC curve and looked for sensitivity and specificity of interferon levels to discriminate active and inactive disease. They found out that interferon alpha levels, the absolute level was 0.49 picogram per ml compared to non-active, which is 0.03. And this had an area under the curve of 0.90, and the p-value was significant. So using the Uden's index, they calculated a threshold of 0.11 picogram per ml, which had a sensitivity of 88 and specificity of 80% to discriminate active versus inactive. For interferon beta, the area under the curve was 0.71. And for interferon gamma levels, they also found a trend between active and inactive, which was significant. And in antisynthetase, interferon alpha levels were again higher as compared to non-active patients, and the area under the curve was 0.69. for interferon gamma, again, the levels were higher in active versus non-active. So basically, they found out that the levels are higher in active than non-active. They found out that the interferon levels are correlating with different disease domains, that is extramuscular, muscular. And they also further found out that these interferons had a correlation with myositis-specific antibodies. So interferon alpha levels were elevated in MDA5 and MI2 as compared to the negative one. And interferon beta levels were significantly elevated in anti-NXP2 and TIF1 gamma patients. So this is a heat map which they gave at the end of the study. Let's try to simplify this. So heat map is basically a visual representation of the study data in terms, and they give the intensity of findings are basically color coded. So we can see active disease is bright red and inactive disease is blue. And the interferon levels are color coded here, green being 0 and red being the highest. So the row below is basically an extrapolation of the dermatomyositis patients and the individual antibodies. So in a subset of dermatomyositis patients with MDA5 positivity, we can see that in active patients, interferon alpha levels were significantly higher. Then in similar findings we can see in if it's P2 in active disease, you can see the red. So this is just, sorry ma'am.
Kiran,
Yes ma'am.
I think we could not hear the last part of what you said.
Okay. Am I audible now?
Yes, now you are.
Yeah. So the column, the row below basically shows an extrapolation of dermatomyositis patients, which are divided into different antibody positivity. So we can see that in MDA5 positive dermatomyositis, in active disease, patients had higher levels of interferon alpha, which is the red. Whereas in NXP2 positive patients, we can see that more patients of active disease had interferon beta levels were high. So this is just a heat map to show, to summarize the findings of the study. So I would like to summarize this study's findings. They had they had studied 222 idiopathic myositis patients, which is a good sample size. Interferon alpha and beta was highly correlated with disease activity in dermatomyositis. And patients with active dermatomyositis had a higher median level of interferon alpha compared to non-active patients. And they also found an association with myositis-specific antibodies, particularly the anti-MDA5 antibody, who had higher levels of interferon alpha compared to other antibodies. So shall I proceed to the discussion?
Yeah, just wait a minute. So can you go back to where you started the result? Yes, so what is a validation cohort? Why have
Validation cohort, yeah. Mainly it is used in studies where we are looking at a diagnostic test or some measure like a biomarker in our case, where we want to confirm the findings of our first cohort. So it mainly increases the internal validity of a study.
Sorry, I have again lost you.
Robustness of a study, basically, that they are in another cohort.
Could you hear that, Sanat?
Hello?
Hello?
No, just say that again fully.
Yes, so a validation cohort is mainly formed to confirm the findings of our preliminary cohort, and it basically increases the internal validity or the robustness of our findings, of a study's findings.
Okay, so first cohort that you use is what?
It was this is the table of the first cohort. It included 152 patients, 50 of dermatomyositis, 46 of antisynthetase, 32 of IMNM, and 24 of IBM. Whereas the validation cohort was a separate cohort which recruited around 70 patients of dermatomyositis and antisynthetase.
So they included two diseases here, right?
In the validation cohort,
The
yes.
validation.
And it was a separate cohort.
Separate in the sense?
Separate in the sense, these similar patients weren't continued into the second cohort. They recruited new patients in the validation cohort.
Okay, so are they talking about reproducibility here, or?
Yes, reproducibility of the results is what I think internal validity is.
So Sanat?
So reproducibility and internal validity is not completely reproducibility, and a validation cohort does not, yeah, maybe in some way improves internal validity, but it's mainly for external validity.
External
So
validity.
essentially, internal validity is whether the results in your own study are correct or not. And external validity is when you ask that will these results apply to somebody else. So
Yes.
truly or intuitively speaking, with a validation cohort, you're trying to get external validity.
Okay.
Yeah, that's why we are using the validation cohort.
And validity and reproducibility are slightly different. So reproducibility is a different metric. It's not included within validity.
Okay.
So in internal validity, there's no true measurement for internal validity. You're just looking at whether there was a selection bias, whether there was confounding, whether there was blinding. So it's more a checklist for internal validity. So you don't truly. So for external validity, you can compare the two, right? Like you can say that my first result in my own population was this, the second result was this, and therefore you can have statistical comparisons of the two. For internal validity, there's not too much, like there's no statistical methods for that much. It's mainly about a checklist about was this done, was that done, those kinds of things.
Yeah.
Yes. Got it.
So just take us through the next slides also.
So did you show the ROC results? I'm curious because did I
So
miss?
they have not, no, they haven't given the ROC curves. They have just mentioned the area under the curve. They have just mentioned the values. I have
Did
put
you
in
show
all the
that?
graphs which were.
She showed that.
Yes, sir.
So these were where were the areas under the curves?
1 second. Yes.
Okay.
Okay, so what does this mean basically? What are we interpreting out of this?
The findings which we get, area and a good area under the curve is mainly one which is closer to absolute value of 1. It mainly indicates that the study model was good and reliable, is what my understanding is. That is the cutoffs which we have calculated for interferon alpha levels, and these cutoffs to differentiate active from inactive disease. This model is a good model, is what area under the curve means.
So at that level, your sensitivity and specificity they've given, right?
At
the level of, so area under the curve at 0.9 means what?
Okay, I didn't think that area under the curve was a particular point.
No. So what is 0.9?
It is the
Where's the diagram that you shown?
yes, ma'am. I'll just go back. I thought this entire thing, it is a parameter which basically a report card of what we have plotted is what I thought.
Okay, Sanat, any inputs on that?
I mean, area under the curve is the blue shaded area that you're showing in this
Yeah.
photo. Yeah.
Yes. So I thought of it like a percentage or a I didn't think of it like a particular point, like at
It's not a
0.9.
point. It's
Yes,
not a point.
not a point.
It is an area.
That is why it's area under curve, right?
Yeah.
Yes.
Okay.
So
Right.
by 0.9, so we have
So it's
different
like
values.
90%, like it's covering 90% of the area of this entire square.
Yes.
Yeah, you're right. And your
Yes.
interpretation was
Yes,
right.
you can go ahead.
With the discussion?
Yes. Unless there's any other point till here. Yeah, you can go ahead.
Okay. So, yes. So interferons and myositis, there is actually plenty of data which is mainly done on interferon signature in myositis. There is just one study which has checked absolute interferon levels in lupus, which I'll be discussing subsequently. And across all the studies, the most reproducible pattern is type 1 interferon, which is seen in dermatomyositis. So this was done in 2007, where they actually used the interferon score to compare the interferon activity in myositis in SLE, and they also compared this score with the disease activity. This is another study where they isolated the interferon score on skin biopsies, and they have various comparators here. So they compared it, they didn't compare, but it was an observational study. So they found out that interferon score was significantly elevated in dermatomyositis biopsies, lupus biopsies, and other viral infections, even a few in scleroderma. So interferon signature has basically been identified in skin biopsies, in muscle biopsies, even in blood in the literature. This is another study which showed these are basically the interferon stimulated genes, and this study compares the gene activation with METAX. METAX is basically a measure of extramuscular disease activity in dermatomyositis. So it shows significant correlation with active disease, which is METAX more than 6. This is another study where they have compared interferon signatures on muscle biopsy specimens of different myositis subtypes. So we can see that interferon 1 inducible genes were highly represented in dermatomyositis biopsies and moderately represented in antisynthetase and less in IMNM and IBM, whereas interferon 2 inducible genes are highly expressed in dermatomyositis, antisynthetase, and IBM biopsies. This was just to show the differential activation of different types of interferon in myositis. So how was our study different? Firstly, we measured interferon levels, which is an upstream cytokine versus downstream biological activity. And we found out that interferon levels, they can correlate with specific organ involvement, even disease domains. But again, a limitation of measuring absolute values is interferon levels have biological variability. They are more specific, but they are less stable. So this was the study which I was talking about of interferon alpha levels, measuring absolute interferon alpha levels in lupus. This is a study which is very similar to us. So even they classified disease population into active versus inactive based on SLEDAI scores. Even they used the Simoa technique for measurement of interferon alpha, and they plotted it on ROC curves to get a cutoff for active versus inactive disease. So ours was the first study to be done in myositis patient. So in this lupus study, they also compared the performance of digital ELISA versus the conventional bioassay and the FAR test. So we can see the area under the curve, which can be used to, as I said, measure the robustness of a model. It is high in digital ELISA as compared to the conventional bioassay and FAR test. Coming to limitations of this study, of our study, it was a cross-sectional assessment. So we cannot see the fluctuation of interferons with flares and remissions. So that is a basic limitation of a cross-sectional assessment. And values of interferons could have been confounded by treatment. They haven't given the exact details of the immunomodulator use in individual patients. And of course, the absence of a universally accepted gold standard for assessing disease activity, which still remains a limitation in most myositis studies. And also, I think they have the big limitation is that they have used different methods for measuring different types of interferons. So for interferon alpha, they have used the standard ELISA. So the sensitivity was more for alpha and gamma than beta. So coming to future research agendas, we need more longitudinal studies to look for fluctuation of interferon levels with disease activity. We need a longitudinal follow-up of the cohort. And we need to find out which interferon protein best reflects true inflammatory activity in each IAM endotype. And if can these blood interferon proteins be linked quantitatively to matched muscle, skin, and lung pathology, that we need to compare it with signatures and interferon levels. And we also need to find out if these endotypes vary with our therapies. For example, JAK inhibition, which is upcoming and has a role in targeting interferons. So I would like to do a critical appraisal of my study using the CASP checklist. Should I proceed?
Yes.
Yes. So coming to the first question, are the results of the study valid? So yes, did the study address a clearly focused issue? Our study had a predefined aim, which was to evaluate biomarkers as assess interferons as biomarker of disease activity. The population exposure and outcome was clearly defined, and they had a clinically relevant problem to start with, which is lack of adequate biomarkers in myositis. Did the authors use an appropriate method or study design to answer their question? Honestly, I think a prospective cohort would have been better to check the interferon fluctuations with disease activity. Were the subjects recruited in an acceptable way? So yes, they were consequently enrolled with a predefined inclusion and exclusion criteria. So yes, they were recruited in an acceptable way. Were the measures accurately measured to reduce bias? No. Mainly a subjective assessment was used for disease assessment, and there was no blinding of assessors. No validated measure was used. That is a basic drawback. That is, interferon levels have not yet been validated. The digital ELISA has not yet been validated, and different measuring methods were used for different types of interferons. Was the data collected in a way that addressed the research issue? So yes, precise data collection method were predefined with appropriate positive threshold cutoffs for each value, for each interferon, sorry. Did the study have enough participants to minimize the play of chance? So yes, they had 222 patients of myositis, but the paper did not give a proper logic behind sample size calculation. And but we had parameters like area under the curve, confidence interval, etc., which suggested that the population was enough, basically. That is, the findings were reliable. So how are the results presented, and what is the main
Sorry,
result?
just go back. Why are you saying
Yes.
that a particular AOC is saying is testament to a good sample size?
Good sample size, no, sir. It is the results are more the results are reliable.
How does an AUC number tell
So
you
we
that
can
the
say the
result is
sample size was
reliable?
adequate to justify the reliable result.
No, but
Results are reliable. I'm
I can
sorry,
have an
but
AUC with 3
I didn't
people
want.
also of 0.9. I can have an AUC of 1 with 10 people if it's absolutely the same. So I don't think that can tell you what result you have got. That can't tell you that is the sample size proper.
Have they calculated sample sizes? How?
They have not mentioned.
They've not
They
mentioned.
haven't mentioned. Yeah, that's what I.
And in number 5, they didn't have positive threshold cutoffs, right? They came to the positive threshold cutoffs from the data itself.
Yes, they had
with
basically.
the
I wanted
Uden
to
points.
no, they had predefined cutoffs even before the patients were recruited in the study. They had predefined positive threshold cutoffs for alpha, beta, and gamma, which they
Okay.
calculated using healthy donors. That is mean plus 3 into standard deviation of healthy donors plus
Yeah.
3 into standard
Okay.
Okay, go ahead.
deviation. That is what I wanted to highlight. Shall I proceed?
Yes, yes.
Hello.
Yeah, please proceed.
Yes. So coming to the 7th point, how are the results presented and what is the main result? We can see that this study mainly gave us median values of interferons, interferon alpha mainly, to differentiate between active versus inactive disease and its correlation with myositis-specific antibodies and different subtypes of IAM. Was the data analysis sufficiently rigorous? So yes, they have given an in-depth description of the analytic process, and it's one drawback I found. They haven't mentioned the immunomodulator use. They have just mentioned the number of patients which were on immunomodulator. Is there a clear statement of findings? So yes, findings have been discussed in relation to the original research question. And can the results be applied to the local population? So yes, they can be applied. But this study was done in a tertiary care center in France, in Paris, in France. So I'm not sure if a role of ethnicity comes into play, and that is a limitation still. And how valuable is the research? So this research definitely paves the path because no such study has been done so far in myositis, a disease where we do not have clear-cut assessment measures available yet. So coming to conclusion, our study supports the role of type 1 interferon, which is alpha and beta, and type 2 interferon, which is gamma, as probable, reliable markers for disease activity in dermatomyositis and antisynthetase syndrome. Myositis-specific antibodies are associated with distinct interferon secretion profiles, which may help guide personalized treatment strategies in future. And interferon can be differentially expressed with different disease domains. Thank you.
Okay, thanks, Kiran. You've taken us through this very well, even through all the statistical, the elaborate statistics that were employed here. Yes, so any comments on this from other viewers, other students who've joined? Or any questions for our discussant? Sanat? Anything else you want to ask?
Yeah. So, do you feel that in clinic this will help you? If you're talking about any new biomarker, there are multiple things that you can measure. Do you think based on these results, it will help you in clinic? And if so, why or how?
So, if we go to see in myositis, yes, it will help us because many a times when we measure the MMT8, it doesn't always correlate with active inflammation. So measuring interferon levels might help me to know the disease activity, and it also helps us to guide therapies. So there are interferon targeted therapies, and even the JAK inhibitors, which are now more available to us, more affordable. They act on the downstream signaling of interferons. So yes, therapeutically and assessment wise, it will definitely help.
So, I mean, I would like to refute that because disease activity is something that you've already measured, even in the paper. You're correlating it with disease
Disease.
activity that you've measured in more traditional ways, clinical and all of the other things combined. What additional information is this giving? You already have very substantive ways of measuring disease activity. I mean, so is it simplifying disease activity measurement? Is it giving you a disease activity measurement that is over and above something that is not picked up by the traditional ones? Is it helping you in some other clinical decision making. These are the kinds of things that you would want to ask about for any biomarker. You don't want to reinvent the wheel in how you measure a disease otherwise. So if it's going to provide additional value, then there is a point in doing this.
So additional value is there because the data is scarce on this in literature. We just have data to support the pathogenesis, that interferon has a role in pathogenesis and interferon signature has been identified in muscle and vessels, etc. But since the data is scarce, yes, it does give an additional value. And we will have to follow it up in future studies to see if it actually, that's what I said, we need more prospective studies to see if it actually correlates with the activity, and more blinded assessments maybe of disease activity.
So suppose a patient has a viral infection, what would their interferon values be?
So it can be elevated.
And
That
it
is
will
what
be elevated, but
it will.
do you have similar cutoffs from other literature? I mean, I know that they've not assessed it in this particular paper,
So
but you also need to look at that from a much wider angle. There are multiple, far more common reasons for increased interferon level. And that's different from an interferon signature. So an interferon signature is a genetically or an epigenetic test, which is going to be more or less constantly increased in a patient with dermatomyositis. And that's valuable. And in knowing that an interferon signature is present epigenetically is valuable because that's a chronic thing. Interferon levels are widely what is the half-life of
fluctuating.
interferon alpha?
Sorry, I don't know.
That is the problem with in cytokine measurements in general. They have extremely short half-lives. Why don't we go ahead and measure TNF, for example, in rheumatoid arthritis? We know that TNF alpha inhibitors are present, and why can't we measure TNF in rheumatoid arthritis and then decide whom to use TNF alpha inhibitors in? Or why similar things like why can't we use IL-6 levels to pick out people who we want to give IL-6 inhibitors in either myositis or this thing or rheumatoid arthritis? Because there is an inherent problem in interferon or interleukin measurements that they fluctuate. There are a huge number of reasons that they will change. It is not at all specific. I mean, it is highly conserved, and you'll find that if you do it 4 times a day, you'll find widely fluctuating levels by virtue of its short half-life. So, I mean, I am highly skeptical, regardless of how nicely the paper has shown, that they'll be clinically useful. I mean, these are my reasons. You would want to make your own reasons before you include them in clinic.
Yeah.
So adaptability of this into practice still remains to be seen. We don't know. Clinical judgments.
Maybe if we can have studies which do combine interferon signature levels with interferon to increase the specificity and good exclusion criteria.
What are the therapeutic implications do you feel of interferon signature in general here in myositis? What are the drugs that you've heard of or are being used already outside or in trials?
So yes, anifrolumab is one which is targets the interferon alpha receptor. But as I said, JAK inhibitors, which are more available in our country now, so they interferon basically signals through JAK-STAT pathway. So JAK inhibitors are anti-interferon. There is some role for I think conventional synthetic DMARDs like HCQS, leflunomide, even they act on the interferon pathway very non-specifically, but yes, so mainly JAK inhibitors. I think they have there is some data on ILDs of antisynthetase dermatomyositis with JAK inhibitors also.
Okay. Any new drug you've come across? Very recent publication. Also, which is targeting interferon pathway somewhat. You heard of brepocitinib? Any paper on that has come, or have you read?
I haven't read.
Okay.
I'll look it up.
Okay, so
So, just one question. So you said that we need longitudinal studies to look at the value of the biomarker. So how would you design such a study? Like what would you assess? What would you do?
So, firstly, I would like to do an RCT where we are having a good comparator.
What would you randomize between?
So basically, I wanted to bring in blinding because many a times if the CK is elevated, the physician global assessment can be biased. That's what I found in this study. So I would like to have sequential assessments of disease activity by blinded assessors who are
Kiran, I think we've
Rosalie?
lost you there. Um,
Sometimes the internet is very convenient.
Kiran, are you there? Yes, she's back.
Okay.
um,
So blinding is to reduce bias between physicians, which is not what you're looking at. You're looking at the value of the biomarker that you have come up with. You or these people have come up with, and you are
um,
sold on. So if you are wanting to, that's what you said, right? In future research that we need longitudinal studies.
yes, mainly
So of
because
the
in this
value of
study,
the biomarker, what kind of longitudinal study would you do? What would you assess? How would you design it?
um, basically, I would take a cohort of diagnosed cases of myositis and compare it with healthy donors. And I would follow up these patients prospectively and do sequential assessments of disease activity, which is assessed by a separate blinded person, and simultaneously measure the interferon levels using the digital ELISA that we have, and monitor the values over a significant period of 1 to 2 years, and compare it, and also see if the therapies are having any effect on the interferon levels simultaneously, if it is decreasing.
Do you need a control group here?
Yeah,
Yes,
why
ma'am.
do you need healthy controls
To
for this?
Need that? So strictly
uh,
speaking, longitudinal study or following up one cohort
yes,
time. Do you need healthy volunteers at all? I mean, healthy controls at all?
ma'am,
You
just
already
to study
established
the
one thing. Now
fluctuation.
you're going to take it to the next level, right? I think we've again lost. Kiran?
Ma'am, I can hear you.
Yes. Could you hear us there?
I can hear you.
You can hear us now?
Yes,
Yes. We're just asking you, do you need
yes,
healthy controls there for your
I
longitudinal analysis?
can hear you.
What do you want to find out? I mean, before you design it, what do you want to find out from your longitudinal analysis? That what information are you looking at? That will help you design a study. Because this study is all over the place. You're trying to differentiate from healthy controls. You
So,
don't need a longitudinal study for that.
Fluctuations of interferon levels even in healthy controls. That is what I wanted to say. If
You
we are
want to
seeing
see if they go up and down even in healthy controls, and then it's completely useless that way.
yes, so because as I said, it is not a very specific marker. That is why I want the healthy controls also to be there to
Okay.
see the.
You really can't realistically follow healthy controls for anything. I mean, what we're trying to say here is there is a particular disease which you're studying, right? There's a cohort of that disease, dermatomyositis, for example, and you're following that up. So you need only that for your
Okay.
study.
I mean, when you're thinking of designing a study, it first should come from a question. So if your question is, so let's say your question is, can interferon levels at diagnosis predict how this patient behaves?
Hmm.
Or what kind of complication
Yeah.
they get later?
Or does it
Or
reduce
how
hair?
does it evolve, or how does it respond to treatment, etc. You don't even need repeated values because it's still a prognostic biomarker when it's done at baseline. The
Diagnosis.
information that you get from clinical follow-up tells you that what you had predicted at baseline, is it correct or not? And in fact, that increases the value of the biomarker by a fair amount. So if I have, let's say, at diagnosis, if I know that interferon alpha is high, and then I know that this group of patients is going to do worse throughout their disease career, not career, like trajectory. Whereas if the people with interferon gamma, I mean, I'm not being specific here, but if these people are going to do better, then that itself is valuable, and that needs longitudinal this thing, but it doesn't need you to keep doing longitudinally repeated measurements.
Okay.
So it depends on what you want to get answered before you start just following up patients and doing more and more tests in them. That's why
Yes.
I was asking you, how would you design something? But before you design something, you'll always need to come up with a question first.
Right.
So even in this particular paper, if they just follow up the same cohort, do nothing else, even with those levels that they already have, they'll be able to give you more information in a subsequent paper.
Right. And we can also study the measurable effect with therapy also. That is also one possible option.
Yes.
Okay. So I think we're done with today's journal club. I think it was a very, very good discussion we had on statistical tests as well, because that is usually the rate limiting step for a
Yeah.
lot of us, right?
Yes, ma'am.
And
Definitely.
well done, Kiran. And it was a good
Thank you, ma'am.
collected. A lot of
Thank
points
you, ma'am.
came out. And thank you, Sanat, for
Yes,
the
thank you.
insights.
Mm.
And thank you, all of you. Thank you for taking out time on a busy Sunday. Thanks.
Thank you, ma'am.
Bye.
Thank you,
Bye.
sir. Bye.